All right, future therapies. The exciting thing about this disease, and since I have a very vested interest in it personally, um, one of the very exciting things is there's a lot of action, a lot of movement, a lot of research in this area. So there's a lot of future therapies. As we talked about the fact that here's the cycle of lung disease, and I focus on lung disease since that typically is what the life-ending problem is we have this CF gene mutation, and really gene therapy is the holy grail here. And gene therapy has been an important part of the research, and there's a lot of action in that area as well. It just, like I said, the gene was cloned in 1989, and we thought that would be the answer, but it hasn't been for many reasons, which I'll talk about in a minute. We also want have things that to actually improve CFR dysfunction. Obviously, the more we are at the actual cause, the better the treatment. And right now we have Trikafta and other modulators and other things in the pipeline that improve the CFTR dysfunction and therefore improve the ion transport defects. We don't have much that actually, this is actually causing this to be improved. By altering the airway secretions, we try to use hypertonic saline, mucolytics, physiotherapy, and that's not spelled right, but other drugs to try to improve the airway secretion. I'll have to get back to you on that one too. So we do have drugs that are attacking this piece of it. We use antibiotics and immunizations to try to improve infection and decrease infection. Oopsie. Inflammation, we haven't been all that successful with. We can also put azithromycin in here that were used to try to improve inflammation. There's study drugs in that area, including sildenafil, which is interesting. Non-steroidals have been shown to work. They're just too many side effects. Same thing with steroids. And then ultimately we have transplant available when there's too much tissue damage. And to date, I think people with lung transplants are living 9 to 10 years after transplant. And that's always improving as well, but we'd rather that we didn't get to that. And I can tell you that I've been told too, with the new CFTR modulators, patients have been taken off transplant lists, which is super exciting. So they were on the transplant list or getting ready to be put on the transplant list because their lung disease was so profound. And once started on these new drugs, they've been able to be taken off the transplant list because they're not sick enough for it. You can always look at this pipeline, which is exciting. I don't know if this will do this. But you can look and see all the different, these are all the gene therapy. I don't know if this is still capturing this, but if it's not, I apologize. But there's many gene therapies, some of them in phase 2, restoring the CFTR protein, which is, what all those modulators do. You can see that there's 4 of those that are available now. Trikafta is by far the most successful. There's other ones that are coming online that'll get some of the other mutations. The mucociliary clearance, we have Dornase alpha, which I mentioned, hypertonic saline, and mannitol. So I guess that's a trade name for mannitol, is another thing that's used for mucociliary to improve the mucociliary situation and trying to restore that somewhat. The anti-inflammatory, again, we have some drugs that are in looking to be or that are in the study pipeline here. A lot of antibiotics, other things like inhaled liquid nitrogen, which is interesting, gallium, other things that are interesting antibiotic approaches. And then for nutrition, there's some new enzymes and ADEX available and other things under It could be taken once a day and that sort of thing rather than with each meal. How do I get back to where I was? I don't know if I just did that for nothing. Maybe I stop share and then share again. Sorry about this. I don't know if any of that worked now. And then finally, I just want to talk a tiny bit about gene therapy. There's a couple of them in phase 2. There's been more than 20 phase 1 trials. None of them have been successful to date. Problems are, and there were some studies done early on where patients died. And so there was a long time where we did no studies. Part of the problem is reaching the site. So they would inhale usually the vectors to actually deliver the new genes are usually some sort of cold virus, so some type of virus that will carry the good genetic information into the cells. And because we know viruses like these will easily infect the lungs, that's what was used. And then there's also, shoot, I can't remember the name of the other transporter, but it doesn't really matter. But vectors are called. So trying different vectors has been what we've been doing. But because of the thick layer of mucus, it's hard to, and bacteria and junk that lines the lungs, it's harder for these vectors to make it through. Okay, that's it. Thank you.